Pulmonary hypoplasia refers to incomplete lung development, characterized by a reduced number of alveoli and fewer airway generations, which limits the total gas exchange surface area. At birth, this structural deficit manifests as severe respiratory insufficiency, often with hypoxemia that is refractory to supplemental oxygen. The degree of compromise depends on the timing and severity of the developmental insult, as even partial reduction in alveolar number can significantly impair lung compliance and ventilation. Early recognition of pulmonary hypoplasia is critical, as these infants are at high risk for immediate respiratory failure and may require advanced ventilation strategies and hemodynamic support from the first minutes of life. Normal lung development depends on three essential factors: adequate thoracic space, fetal breathing movements, and sufficient amniotic fluid volume to distend the airways. Thoracic space allows the lungs to expand and form alveoli. Compression from masses, pleural effusions, or skeletal constriction impairs alveolar and vascular growth. Fetal breathing movements mechanically stimulate lung expansion and promote proper branching of airways and vasculature. Adequate amniotic fluid ensures airway distension and supports alveolar maturation. Disruption of any of these factors, whether due to congenital diaphragmatic hernia, oligohydramnios, thoracic skeletal abnormalities, or neuromuscular impairment, results in hypoplastic lungs with thickened septa and reduced compliance. These structural deficiencies are central to the pathophysiology of pulmonary hypoplasia and underlie the severe respiratory compromise observed at birth. Understanding these embryologic principles clarifies why certain prenatal conditions are strongly predictive of postnatal respiratory failure. Pulmonary hypoplasia develops when the normal interplay between lung growth, airway branching, alveolar formation, and vascular development is disrupted. Primary hypoplasia, though rare, arises from intrinsic abnormalities in lung tissue differentiation, affecting the epithelial and mesenchymal components required for alveolar and airway formation. In these cases, the lungs fail to achieve normal alveolar number and surface area, resulting in severe hypoxemia at birth. Secondary hypoplasia is more common and results from external or environmental insults during fetal life. Extrinsic compression, such as from congenital diaphragmatic hernia, large pleural effusions, or space-occupying pulmonary or mediastinal masses, mechanically limits lung expansion, reducing airway branching and alveolar proliferation. Amniotic fluid abnormalities, including oligohydramnios or prolonged preterm rupture of membranes, limit airway distension and reduce the mechanical forces needed for alveolar growth. Impaired fetal breathing movements, often due to neuromuscular disorders or central nervous system abnormalities, further reduce stimulation of lung expansion and vascular development. The cumulative effect of these mechanisms is a structurally underdeveloped lung with thickened septa, diminished functional residual capacity, and reduced pulmonary vasculature. These changes compromise compliance and gas exchange and contribute to persistent pulmonary hypertension after birth. Recognizing the specific pathophysiologic mechanism allows clinicians to anticipate severity, tailor delivery room preparation, and guide the need for advanced respiratory support, ventilation strategies, or extracorporeal support in the neonatal period. Pulmonary hypoplasia arises from a set of distinct etiologic categories, each affecting lung development through mechanical, fluid, or structural constraints. Thoracic space restriction is a major contributor, seen in conditions such as congenital diaphragmatic hernia, large pleural effusions, congenital pulmonary airway malformations, or bronchopulmonary sequestration. These lesions physically compress the lungs during fetal development, limiting airway branching, alveolar proliferation, and pulmonary vascular growth, which directly reduces functional residual capacity and surface area for gas exchange. Amniotic fluid abnormalities, including oligohydramnios from renal agenesis, obstructive uropathy, or prolonged premature rupture of membranes, impair airway distension and reduce the mechanical stimulation necessary for alveolar maturation. Skeletal dysplasias, such as thanatophoric dysplasia, achondrogenesis, and osteogenesis imperfecta type 2, result in a narrow, bell-shaped thorax with short ribs, which physically constrains lung expansion and significantly increases lethality. Non-immune hydrops fetalis contributes via fluid overload, including pleural effusions, ascites, and generalized edema, which compresses lung parenchyma and may impair fetal swallowing, further reducing amniotic fluid and lung expansion. Each of these etiologies can act independently or in combination, and the degree and timing of the insult largely determine the severity of hypoplasia. Early recognition of the underlying cause informs prenatal counseling, guides delivery planning, and helps anticipate the level of respiratory support and potential need for interventions such as gentle ventilation, high-frequency oscillatory ventilation, or extracorporeal support after birth. Oligohydramnios sequence, or Potter syndrome, develops when fetal urine production is absent or severely reduced, leading to decreased amniotic fluid. Bilateral renal agenesis is the classic cause, but severe cystic dysplasia or obstructive uropathy, such as posterior urethral valves or urethral atresia, can also result in the same sequence. Reduced amniotic fluid limits lung distension and mechanical stimulation during fetal breathing movements, preventing normal airway branching, alveolar formation, and pulmonary vascular development. The result is structurally underdeveloped lungs with thickened alveolar septa and low functional residual capacity, producing pulmonary hypoplasia that is usually lethal without intervention. Beyond the lungs, oligohydramnios causes physical compression of the fetus, producing characteristic facies: flattened nose, low-set ears, micrognathia, and hypertelorism, and orthopedic anomalies including limb contractures, clubfoot, and spade-like hands. Growth restriction is common, and associated renal or genitourinary anomalies can further compromise survival. Prenatal ultrasound may show absent or small kidneys, an empty bladder, and reduced amniotic fluid volume. The severity of pulmonary hypoplasia can be estimated using thoracic to abdominal circumference ratios or observed to expected lung volumes on ultrasound or fetal MRI. The pathophysiology explains why even aggressive postnatal interventions are often insufficient. The lungs are structurally limited rather than functionally deficient. This understanding guides perinatal counseling, helps set realistic expectations for survival, and informs decisions about the intensity of delivery room resuscitation, ventilation strategies, and whether interventions such as gentle ventilation or extracorporeal support are likely to be beneficial. Timing and severity of the insult are the strongest predictors of postnatal outcome, and early prenatal recognition is critical for planning care and family counseling. The clinical features of Potter sequence reflect the combination of pulmonary hypoplasia and the mechanical effects of fetal compression. Pulmonary hypoplasia is the primary determinant of survival, manifesting at birth as severe respiratory insufficiency, often refractory to standard oxygen therapy due to small alveolar numbers and low lung compliance. Infants frequently require immediate intubation and advanced ventilation strategies. Characteristic facial features include a flattened nose, low-set ears, micrognathia, and widely spaced eyes, hypertelorism, resulting from compression of the fetus within the limited amniotic fluid environment. Limb anomalies, such as limb contractures, clubfoot, and spade-like hands, arise from restricted movement in utero. Additional associations may include intrauterine growth restriction and coexisting renal or genitourinary anomalies, which contribute to both mortality and long-term morbidity. These features provide diagnostic clues prenatally and postnatally, enabling early recognition of the syndrome, anticipation of respiratory compromise at delivery, and planning for appropriate resuscitative and ventilatory support. The constellation of pulmonary and extrathoracic findings underscores the systemic impact of oligohydramnios and informs counseling regarding prognosis and likely interventions. Prenatal evaluation of infants at risk for pulmonary hypoplasia focuses on ultrasound and, when indicated, fetal MRI to assess both lung development and overall fetal condition. Ultrasound can detect anhydramnios or oligohydramnios, absent bladder or empty renal fossae, which suggests severe renal compromise and risk for Potter sequence. Thoracic predictors of lethality include a thoracic to abdominal circumference ratio below 0.6 and observed to expected lung volumes under 25 to 30%. Experimental fetal interventions, such as serial amnios infusions for renal agenesis or vesicoamniotic shunting for obstructive uropathy, have been attempted to improve lung development, though results are limited. MRI provides more precise quantification of lung volume and can confirm findings when ultrasound is equivocal, particularly in borderline cases. Prenatal predictors help anticipate postnatal severity, guide delivery planning, and inform multidisciplinary counseling, allowing the neonatal team to prepare for potential immediate respiratory support, gentle ventilation strategies, and consideration of advanced modalities such as high-frequency ventilation or extracorporeal support. Infants affected by Potter sequence often present at birth with severe respiratory failure due to pulmonary hypoplasia. Preparation for delivery should anticipate profound airway and ventilation challenges. The resuscitation team should include neonatology and anesthesia, with large bore needles available for potential emergent thoracentesis or paracentesis if pleural effusions or tensicytes compromise ventilation. Bag mask ventilation is generally ineffective and may worsen lung injury. Early endotracheal intubation is essential to establish a secure airway and enable controlled ventilation. Gentle ventilation with low peak inspiratory pressures and permissive hypercapnia may be required if any alveolar function is present. Hemodynamic support should be ready, including rapid fluid resuscitation through umbilical venous access if anemia or shock is suspected. Early echocardiography is recommended to assess cardiac function and identify structural lesions, which may affect oxygen delivery and guide resuscitative strategies. Assessment of viability depends on the underlying cause. Bilateral renal agenesis is almost universally lethal despite maximal support, whereas obstructive uropathies may be survivable if renal replacement therapy is feasible postnatally. Prenatal counseling should provide families with realistic expectations, including discussion of resuscitation limits and likely outcomes, so that delivery room planning aligns with both clinical possibilities and family goals. Skeletal dysplasias, such as thanatophoric dysplasia, achondrogenesis, and osteogenesis, imperfecta type 2 can severely restrict thoracic space, directly impairing lung development. These disorders are characterized by short ribs, a narrow bell-shaped thorax, and abnormal ossification, which limit the ability of the lungs to expand, resulting in life-limiting pulmonary hypoplasia. Prenatal imaging often demonstrates a thoracic circumference below the 5th percentile, or a thoracic to abdominal circumference ratio under 0.6, which correlates with lethality. Additional skeletal features, including fractures, bowing, and abnormal mineralization, are common and may further compromise chest wall compliance. The severity of thoracic constriction, combined with abnormal rib development, predicts both the degree of pulmonary hypoplasia and the likelihood of postnatal respiratory failure. These factors guide prenatal counseling, delivery planning, and immediate postnatal respiratory strategies, as affected infants often require advanced ventilation or may be non-viable depending on thoracic capacity and residual lung tissue. In congenital diaphragmatic hernia, abdominal viscera herniate into the thoracic cavity, mechanically compressing the developing lungs. This compression reduces airway branching, alveolar formation, and pulmonary vascular development, leading to hypoplastic lungs with decreased compliance and reduced surface area for gas exchange. Prenatal severity is influenced by the presence of liver herniation into the chest and can be quantified using the observed to expected lung-to-head ratio. The resulting pulmonary hypoplasia explains the immediate respiratory insufficiency seen at birth, often complicated by persistent pulmonary hypertension. Anticipation of these challenges allows the perinatal team to plan for prompt intubation, gentle ventilation strategies to avoid barotrauma, and potential use of high-frequency ventilation or extracorporeal support. Prenatal detection of CDH also permits multidisciplinary counseling and preparation for postnatal interventions, improving the likelihood of stabilizing these high-risk infants despite structural lung limitations. Non-immune hydrops fetalis occurs when fluid accumulates in two or more fetal compartments, such as pleural effusions, ascites, or generalized edema, without red cell alloimmunization. The underlying mechanisms include fetal heart failure, anemia or venous lymphatic obstruction, leading to fluid overload and impaired lymphatic drainage. The resulting thoracic and abdominal distension can compress the lungs, limiting lung expansion and exacerbating pulmonary hypoplasia. Prognosis is poor if hydrops develops early, particularly before 20 weeks gestation. Prenatal interventions such as thoracoamniotic shunts may be attempted to drain pleural effusions, but success is variable and often temporary. Early recognition via ultrasound or fetal MRI allows the team to anticipate severe respiratory compromise at birth, plan for airway management, and prepare for potential emergent procedures to relieve thoracic or abdominal pressure. These measures are critical to improving survival and guiding counseling regarding expected outcomes and the intensity of postnatal support. Infants with non-immune hydrops fetalis often present at birth with profound respiratory compromise due to pleural effusions, ascites, and generalized edema compressing the lungs and thoracic structures. Preparation for delivery requires a coordinated, multidisciplinary team, including neonatology, anesthesia, and resuscitation personnel, with equipment for airway management and emergent fluid drainage immediately available. Large bore needles should be ready for thoracentesis or paracentesis to relieve pleural or abdominal compression if ventilation is severely compromised. Bag mask ventilation is frequently ineffective because the hypoplastic, compressed lungs do not expand properly, and positive pressure may exacerbate pulmonary injury or fluid shifts. Early endotracheal intubation is essential to secure the airway and allow controlled ventilation. Gentle ventilation strategies with low peak inspiratory pressures and permissive hypercapnia help avoid barotrauma while maximizing oxygenation in the limited lung tissue. Rapid vascular access, typically via the umbilical vein, allows for immediate fluid resuscitation if anemia or shock is present, and early echocardiography is recommended to assess cardiac function, structural anomalies, and the degree of pulmonary hypertension. Delivery room assessment must also consider viability. Hydrops caused by severe anemia or early onset cardiac failure has a poor prognosis, whereas some obstructive lesions may be survivable if postnatal therapy is feasible. Anticipatory planning and real-time intervention are critical to optimize outcomes in these high-risk infants. Ultrasound provides critical early indicators of pulmonary hypoplasia. Thoracic measurements, including thoracic circumference in the 4-chamber heart view and the thoracic to abdominal circumference ratio, can identify fetuses at high risk. A ratio below 0.6 is strongly predictive of severe hypoplasia. Additional features include a heart-to-chest ratio greater than 50% and ribs encircling less than 70% of the thoracic circumference, often producing a bell-shaped or concave thorax. Detection of anhydramnios or oligohydramnios, absent bladder, or abnormal renal structures further supports risk stratification, particularly in oligohydramnios sequence or Potter syndrome. These sonographic parameters allow clinicians to anticipate the degree of lung underdevelopment, guide delivery planning, and inform discussions with families regarding expected respiratory compromise, the likelihood of advanced ventilation, and potential need for extracorporeal support. Ultrasound remains the primary tool for evaluating lung growth in utero and is essential for identifying fetuses who may benefit from multidisciplinary perinatal management. Fetal magnetic resonance imaging offers detailed assessment of lung volume and thoracic anatomy when ultrasound findings are equivocal. Observed to expected total lung volume below 47.9% indicates poor prognosis in skeletal dysplasias, while volumes below 25 to 30% are often predictive of lethality in congenital diaphragmatic hernia cohorts. MRI also provides precise visualization of residual lung tissue, the degree of mediastinal shift, and structural relationships of the thoracic cavity, which helps refine risk assessment in borderline cases. Although useful, MRI measurements are limited by variability in nomograms between centers, so findings must be interpreted in context with gestational age, thoracic dimensions, and amniotic fluid status. Accurate quantification of lung volume allows prenatal teams to anticipate postnatal respiratory insufficiency, prepare for advanced ventilation strategies, and guide delivery planning, including the need for tertiary-level neonatal care and potential extracorporeal support. Infants with pulmonary hypoplasia typically present immediately after birth with severe respiratory failure. They exhibit profound hypoxemia that is often refractory to supplemental oxygen, and low lung compliance limits tidal volumes even with high ventilatory pressures. The lungs are structurally underdeveloped, with reduced alveolar numbers and thickened septa, which compromises gas exchange. Pulmonary hypertension frequently coexists due to abnormal vascular development and increased pulmonary vascular resistance, further impairing oxygenation. These infants often require prompt endotracheal intubation, careful ventilatory support, and close hemodynamic monitoring. The severity of respiratory compromise correlates with the underlying cause, degree of lung underdevelopment, and associated anomalies, making early recognition critical for optimizing postnatal stabilization, delivery room interventions, and decisions regarding advanced support such as high-frequency ventilation or extracorporeal membrane oxygenation. Postnatal diagnosis of pulmonary hypoplasia combines imaging, physiologic assessment, and exclusion of other causes of respiratory failure. Chest radiography often demonstrates small lung fields with low volumes relative to gestational age. Arterial blood gases reveal profound hypoxemia despite high fractions of inspired oxygen, reflecting impaired alveolar gas exchange. It is essential to rule out coexisting structural causes such as congenital diaphragmatic hernia, pleural effusions, or airway obstruction, which may contribute to or mimic hypoplasia. Definitive confirmation is obtained through histologic evaluation or autopsy, showing reduced radial alveolar counts and underdeveloped pulmonary architecture. Early recognition allows for tailored ventilatory management and anticipation of complications, such as persistent pulmonary hypertension. Postnatal diagnostic clarity is critical for guiding respiratory support, hemodynamic stabilization, and long-term prognostic counseling for families. Initial stabilization of infants with pulmonary hypoplasia focuses on securing the airway and minimizing additional lung injury. Endotracheal intubation at delivery is recommended, while bag mask ventilation is generally avoided due to the risk of barotrauma and poor alveolar recruitment. Maintaining normothermia is essential, as hypothermia increases oxygen consumption and can exacerbate respiratory compromise. Metabolic derangements, including acidosis or electrolyte imbalances, should be corrected promptly. Handling of the infant should be minimized to reduce oxygen demand and prevent abrupt increases in pulmonary vascular resistance. Early establishment of vascular access allows for rapid fluid resuscitation if hypotension or shock is present. The primary goal during this initial period is to support gas exchange in the structurally underdeveloped lungs while preparing for ongoing ventilatory support and potential escalation to high-frequency ventilation or extracorporeal membrane oxygenation if residual lung function is insufficient. Ventilation strategies for pulmonary hypoplasia aim to maximize oxygenation and carbon dioxide clearance while minimizing lung injury in structurally underdeveloped lungs. Gentle ventilation with low peak inspiratory pressures is essential to avoid barotrauma, as hypoplastic lungs have fewer alveoli and limited compliance. Permissive hypercapnia is often tolerated to maintain alveolar recruitment without overdistension. High-frequency oscillatory ventilation can be used when conventional ventilation fails to achieve adequate oxygenation or ventilation. This mode delivers very small tidal volumes at rapid frequencies, allowing alveolar recruitment at lower airway pressures. Both conventional and high-frequency strategies require careful monitoring of oxygenation, ventilation, and hemodynamics to reduce the risk of volutrauma, atelectasis, and exacerbation of pulmonary hypertension. The choice of ventilatory approach is guided by residual lung function, severity of hypoplasia, and response to initial supportive measures, ensuring the most lung-protective strategy for each infant. Adjunctive therapies in pulmonary hypoplasia are aimed at supporting oxygenation, reducing pulmonary vascular resistance, and addressing secondary complications, but their efficacy is limited because the primary problem is structural underdevelopment of the lungs. Inhaled nitric oxide is sometimes used to selectively dilate pulmonary vessels and improve oxygenation in infants with persistent pulmonary hypertension, though response is variable due to the abnormal vasculature in hypoplastic lungs. Sildenafil can be used as a systemic pulmonary vasodilator in refractory cases to reduce right ventricular afterload and improve pulmonary blood flow. Exogenous surfactant may be administered if alveolar instability is present, but its benefit is often modest because hypoplasia reduces the total number of type 2 alveolar cells. Supportive measures such as maintaining hemoglobin above 15 grams per deciliter, optimize oxygen delivery, and careful management of systemic blood pressure ensures adequate perfusion to vital organs. Each intervention must be tailored to the individual infant's residual lung function, severity of pulmonary hypoplasia, and degree of associated pulmonary hypertension. These therapies serve primarily to stabilize oxygenation and buy time for lung growth and recovery, rather than to correct the underlying structural deficits. Extracorporeal membrane oxygenation is considered for infants with pulmonary hypoplasia who have severe hypoxemia or hypercapnia despite maximal conventional or high-frequency ventilation. Its effectiveness is largely dependent on the amount of residual functional lung tissue, as ECMO provides cardiopulmonary support but cannot replace gas exchange capacity in structurally absent alveoli. VAECMO is commonly used when both respiratory and circulatory support are required, while VVECMO may be selected for isolated respiratory failure. During ECMO, lung rest strategies are employed, including low ventilatory pressures and minimal oxygen supplementation to prevent additional barotrauma. Outcomes are generally better in moderate hypoplasia, where some lung parenchyma is present. In severe cases with extreme alveolar underdevelopment, survival remains limited despite ECMO support. Timing of ECMO initiation, residual lung volume, and management of coexisting pulmonary hypertension are key factors determining both immediate survival and long-term respiratory outcomes. Survival in pulmonary hypoplasia depends on the underlying etiology, timing, and severity of the developmental insult. Infants with mild to moderate hypoplasia may survive with intensive respiratory support, though many develop chronic lung disease, bronchopulmonary dysplasia, or persistent pulmonary hypertension. Severe hypoplasia, as seen with bilateral renal agenesis, early onset oligohydramnios, or lethal skeletal dysplasias, is usually incompatible with life. Postnatal outcome is strongly influenced by residual lung volume, the presence of associated anomalies, and the infant's response to initial stabilization and ventilatory support. Even survivors often experience neurodevelopmental delays, particularly after prolonged intensive care or mechanical ventilation. Early identification of high-risk infants allows prenatal counseling, anticipatory planning for advanced respiratory support, and coordination of multidisciplinary care to optimize survival and minimize long-term complications. Infants who survive pulmonary hypoplasia are at risk for multiple long-term complications. Chronic lung disease is common, often requiring prolonged oxygen therapy and exhibiting features similar to bronchopulmonary dysplasia. Persistent pulmonary hypertension may continue, necessitating ongoing cardiopulmonary monitoring and pharmacologic management. Feeding and growth difficulties frequently arise due to poor respiratory reserve, underlying comorbidities, or prior prolonged intensive care. Neurodevelopmental delays are also prevalent, particularly in infants who experienced prolonged hypoxemia, mechanical ventilation, or extracorporeal support. These long-term sequelae underscore the importance of multidisciplinary follow-up, including pulmonology, cardiology, nutrition, and developmental specialists to optimize functional outcomes, monitor growth, and address cognitive or motor deficits as early as possible. Pulmonary hypoplasia results from structural underdevelopment of the lungs, most commonly due to oligohydramnios, Potter sequence, congenital diaphragmatic hernia, skeletal dysplasias, or non-immune hydrops fetalis. Key prenatal predictors of severity include a thoracic to abdominal circumference ratio below 0.6 and observed to expected lung volumes under 25 to 30%, which correlates strongly with lethality. Management at birth emphasizes gentle ventilation to minimize barotrauma, avoidance of bag mask ventilation, and correction of metabolic derangements. High-frequency oscillatory ventilation may be employed for severe hypoxemia, And extracorporeal membrane oxygenation is considered when residual functional lung tissue is sufficient. The prognosis is primarily determined by the timing and severity of the developmental insult, as well as the presence of associated anomalies. Survivors are at risk for chronic lung disease, persistent pulmonary hypertension, feeding difficulties, and neurodevelopmental impairment, making multidisciplinary follow-up essential to optimize long-term outcomes.